to speak about surgical treatment of aortic valve endocarditis and also mitral valve endocarditis. Objective of first lecture, aortic valve endocarditis, I'm going to speak about epidemiology, pathology and pathogenesis, microbiology for native and prosthetic valve, and also clinical presentation and diagnosis. I will specify an acute and subacute or chronic infective endocarditis, and also the treatment, surgical treatment, and clinical result of infective endocarditis in aortic position. This is just a picture to give you a hint about the result and devastating destruction of the valve during infective endocarditis. This is the native valve. You can see the thickening and the perforation in the leaflets. And here the prosthesis valve, if you can see also the vegetation. For the most common valve affected by infective endocarditis is the aortic valve. And the clinical feature of that can be fever, heart murmur, either new or worsening heart murmur present before, splenomegaly, embolic events, and bacteremia or fungemia, depending upon the organism. The most key point in the infective endocarditis is to early diagnose the disease and to promptly treat it with antibiotic. Epidemiology, mostly the predisposing lesion in the aortic valve. Most common lesion is the congenital bicuspid aortic valve. This is the most common lesion which precipitate to aortic valve infective endocarditis. The other degenerative calcific aortic stenosis and aortic regurg due to any causes, and also rheumatic aortic valve. The annual incidence of and the prevalence of aortic infective endocarditis, it's changeable, but which we come across, it's native aortic valve, it's giving 1 to 7 episodes per 100,000 person per year. And in prosthesis, it's much higher, it's 0.2 to 1 episode per 100 patient years. And the prosthesis infective endocarditis, we can divide it into early and late. The early one, it's having higher incidence, 1.4%. And we have for the late or nosocomial infections or late infective endocarditis, almost all related to invasive procedure which the patient have it, like the hemodialysis and dental procedure, endoscopy, and also intravenous user. All of them will precipitate the infective endocarditis. The most higher mortality is the patient who's having hemodialysis. Once he develops the infective endocarditis, there will be a higher rate of mortality. Pathogenesis, I'll go in stepwise. Endocardial injury, the first step. Once the endocardial injury happen due to the causes which we are, or the lesion which present before, then the deposition of platelet and fibrin occur. Then after that, any circulating organism will adhere and attach to that area. And the organism usually produce virulent factor and enzyme depending on the organism, and usually forming a biofilm where he can resist and resist the antibiotic and the host immunity, and also to destruct the host tissues. The primary site of affecting the infection is the valve cusp and leaflet. Then after that, if it's progression, it will go with the valve annulus, then the invasion disease. This is which we try to avoid it and to diagnose it earlier. The invasion disease, it usually occur in stages, started with the cellulitis, then abscess cavitation, then after that, pseudoaneurysmal formation. If the invasion it's reached to aortic root, This is the most dangerous one because it's the invasion will be deeper, and also it's also constantly on highly pressure, which causing more destruction and more invasion. The sequelae of that will go with the internal fistula and the perforation, and also the heart block, especially with the aortic root. It will invade the right atrium at the triangle of Koch and invade the AV node there. In presence of prosthesis, we can see the infected endocarditis as dehiscence, where the ventricular aortic separation happen, and the interface between the prosthesis and the annulus will be separated. Then one of the other sequelae is systemic emboli, will causing cerebral infarction, and if it's going to the brain and or if it's go to other organ, will cause abscess in spleen, in liver, in kidney, or limbs. And the large vegetation in the aortic valve, it's causing usually, which we call it a kissing lesion, where it can directly attach to the anterior mitral leaflet and causing windsock lesion, which is perforation into the anterior mitral leaflet. If the bioprosthesis valve infected, usually the site of involvement is the cusp. This is one, and the other site is sewing ring. Usually start locally, then extend all around the circumferential. And in the aortic valve allograft infection or pulmonary autograft, it's usually similar to the native valve. And it's begin with the aortic cusp, then going and showing aortic regate. Sorry. And or if it's starting at the suture line, it will be extend surrounding the structure and will invade. For the mechanical valve, usually along the sewing ring only, the cusp metallic and cannot be infected. This picture is just showing the endocarditis involving the allografts. Here in A, you can see this is the allograft, and the vegetation or invasion, it's extend up to the right atrium, yes. And here you can see atrioventricular also node, it's penetrating the right atrium. And in the C, the arrow showing the vegetation, and this is LVOT and this is tricusp, and it's attaching to the right atrium also. Atrioventricular node after opening the right atrium. In the D, you can see the after removal of allograft and debride the whole area, and you can now after debridement you can proceed your surgery. This is for a mechanical valve. As you see here, the infected is involved the whole circumferential of the, and also here all the circumferential of the annulus. And this is this picture after debridement. And this is the fungal endocarditis. You can see, which is the hallmark of fungal infection. It's very large vegetation, and here also after debridement. For microbiology, it's depend upon whether the valve is native or prosthesis, because they are different organisms, and the infection is where he get it. Is it community acquired or hospital acquired? And usually also there is a culture negative endocarditis, where no microorganism can be cultured, but we can proceed with the advanced investigation as PCR and to culture the atypical organism also, to be sure. This is in the native valve, mostly staph aureus, which is extremely virulent, and the coagulase negative epidermitis, which is less virulent, but has a very prolonged course, and for the staph, it can forming the abscess, and for the other gram-negative bacteria, it's less common, but the hallmark is resistance to antibiotic. And there is a group of hack group, we should know them. All of them, they have a prolonged incubation period, so it will have longer time to be to growth, and also hair fastidious characteristic. For fungal infection, it's rare, but once happen, it's serious and very difficult to eradicate. Even we need IV antifungal, then after that, lifelong oral antibiotic to be taken. And there is Candida albicans as an example, and Aspergillus fumigatus. For prosthesis, as we mentioned before, there is early aortic valve infected endocarditis and late. The early it occurs within the first year of surgery, and the late one it occurs after first year. Source of infection or contamination in the early infected endocarditis, it's usually perioperative bacteremia. Bacteremia is there. Usually he's going for dental just nearby, or other procedures, or he's on hemodialysis, or our part, which is operative field, he gets an infection from us. The more common organism is staph epidermitis, then after that staph aureus. For the late infection, source usually difficult to be decided, but usually nosocomial infection, it's most one which we are think about and to be afraid of, because especially if the patient doing procedure. Common organism, strep, and then after that staph. For clinical presentation, as we divided before, acute and subacute and chronic, they are usually divided the clinical presentation like this. Before the antibiotic, there was just how long it would take the patient to die. He died earlier, we will call it as an acute. If they die late, they are just mentioned as subacute or chronic. But for subacute, usually caused by less virulent microorganism, as we mentioned before, staph viridans, which take prolonged course, and also the antibiotic alone can be cured. Most cases, if you are treating it earlier and before any invasion have been occurred. Also, the presentation of this low-grade fever, which most of them unspecific presentation, low-grade fever and malaise, but to be sure, no extra cardiac source of bacteremia. So all the sources only in the heart, valve murmur, and splenomegaly, clubbing, and the skin mucosal membrane. This is occur very late, as a petechia, splinter hemorrhage, Whistler node. All of them chronic and late presentation. And there is also embolization, one of them, but once it happens, it can go to the brain causing stroke, or to the myocardium causing acute infarction, or spleen, or even hepatic infarction. For hematological picture, we have leukocytosis moderately elevated, anemia, but without reticulocytosis, so there is no bone marrow activation. But if you get a blood culture, it will be positive. In acute course, it's usually causing by aggressive and virulent organism, as a staph aureus, and this the course is fast and quick, and antibiotic alone cannot be cure the infection. Presentation again, fulminant course. There is usually non-cardiac source, so you have to look at the source of this infection, and more severe and progress rapidly. So the patient maybe will be in septic shock, and we have to interfere earlier. The only two presentation limited to the acute part, it's Janeway lesion and rough spots, which both of them immunological reaction and related to the acute infection. And how it's happened once the aortic valve infected will causing severe aortic insufficiency. Then after that will heart failure will occur. Then invasion, paravalvular abscesses, which is most common complication. Then invasion behind the central or fibrous body, which causing heart block if it's invade the right atrium. Here in acute, usually the blood culture also will be positive. We are following the criteria. For diagnosis, Doppler echocardiography, it's most important. Sensitivity of TE versus transthoracic. TE, it's 90 to 100%. For transthoracic, 40 to 60. And even TE can detect vegetation as small as 1 to 2 mm, and also can detect paravalvular abscess and cardiac fistula. So although sometimes they are missing those lesions. This is the modified Duke criteria. There is major and minor criteria. I will not go through them, but just to know that we have to diagnose the infectious endocarditis, we have to have 2 major criteria, or 1 major and 3 minor, or 5 minor criteria. And also to know the HAC group, which is Haemophilus and Astenobacillus and Cardiobacterium and Echinella and Candela. For treatment, we should use appropriate antibiotic treatment and based on sensitivity, cultural sensitivity, and time. It's important for us and to be started antibiotic as early as possible, because once disintegrated the cusp, disintegrated the tissue of the cusp cannot be regenerated and cannot be healed. So the prompt treatment and antibiotic therapy should be started early. For the treatment, we have 3 parts. The first part is high dose and combined with 2 or 3 antibiotics with IV antibiotics to be continued for 6 weeks. This is mandate. And also to keep in mind to take a blood culture before starting 2 to 3 in separate from separate site, and also to be repeated the blood culture again within 48 hours just to ensure the antibiotic is working. And then after that, surgery. Usually, if the patient poorly responds clinically to antibiotic, or the evidence of progression of the disease by echo or by echo, and or the mobile vegetation larger than 10 millimeter. So all of them, we have to operate area. For the anticoagulant, it's neither indicated nor effective to prevent embolization. Only that increase the risk of neurological complications, especially with hemorrhagic stroke. For preoperative consideration, we have to have a coronary angiography for the patient more than 40 years, but we have to keep in mind if the vegetation in the aortic valve, and we cannot cross the valve during during the catheterization, we will not causing any stroke and vegetation and emboli from the vegetation. And the other alternative, CT coronary, especially with the young patient or with the patient who have large vegetation. For the neurological evaluation, we have to have assessment by CT or MRI, as we mentioned before in the guideline. And post-operatively, complications are common after surgery, especially in active, if we're operating on patient with active infectious endocarditis, as sepsis, hypotension, severe coagulopathy and bleeding, which is expected with this infection, and we have to have ensure the hemostasis after surgery and packing for 20 to 30 minutes. And also we have to have products, blood platelet and cryo, and antifibrinolytic agent as amino carboic acid can be used, especially in reoperation. For the heart block can be occur, especially if there is invasion, and even with our debridement, it can be causing heart block, permanent heart or heart block. So we have to insert a permanent pacemaker during surgery. And the other complication we have to look at it, multi-system organ failure from showering or abscess collection outside the heart, and also metastatic abscesses. For delaying surgery, there is only the neurological complication. In the non-hemorrhagic stroke, we are delaying just 1 to 2 weeks. As we mentioned before in guideline, just we are awaiting to improve the symptoms from neurological side. And for hemorrhagical stroke, we have to have delayed 3 to 4 weeks, and he have a higher risk of bleeding. And both of them we have to wait the risk of surgery with the to wait the risk of surgery with need of patient to do him earlier, and bleeding risk also. For surgical treatment. For surgical treatment, depend upon the site of infection. We are usually going median sternotomy, and T should be there intraoperatively, and we are transfer aortotomy will be done 1 centimeter just above the RCA. If the infection is limited to the cusp, we will remove and divide the infected tissues and replaced or repaired, depend upon. If it's the native valve, we are trying repair and preserve the valve using with the autologous pericardium. But if he is having a history of hemorrhagic stroke, we will avoid the mechanical valve for sure. For infection, and usually in the aortic position, the repair it's less common than the replacement. An infection of invasive to beyond the leaflet, which involving the annulus, we have to resect all the infected tissue and foreign material, and then we have to reconstruct. We will speak about the reconstruction. In the invasion of aortic root, the aortic allograph should be used, and the internal diameter to be 2 to 3 millimeter less than the diameter of the annulus. And usually LVOT must be always preserved and to be in the expert surgeon. And the landmark to indicate the level of proximal suture where we are going to put our suture. It's intervalvular fibrosa with the 2 trigon. And sure, once the aortic root is involved, we have to mobilize the coronary bottom. For infection extended into the intervalvular fibrosa in between the aortic and mitral, the patch of the defect, which we are resected, and we have to have, before prosthetic valve is implanted, we have to just a small patch we can cover by autologous pericardium. If it's a small defect, sorry. If it's large defect, we can cover it with bovine pericardium. For the pulmonary autograph, it's an alternative for allograft in young patients especially. For the clinical result, prognosis of aortic valve infection endocarditis depends upon the stage where we are diagnosing the patient and the microorganism which is involved, virulent or less virulent, and the way we are treating it. It it is replacing by prosthesis, is it repairing? So it depends on that. And surgical result depends on the patient characteristic, either young, their different time of surgery, emergency or urgent, and the type of surgery also play a role. Type of affected valve, is it prosthesis or the native valve? The infection where he gets it, is it nosocomial or community? And nosocomial usually higher mortality. And also the surgeon experience and the institution experience to deal with the affected endocarditis. For operative mortality, a native valve with non-invasive disease 10%, for prosthetic valve usually 20 to 30%. And this is the graph showing same the outcome. The aortic valve survival rate higher than the mitral, and here in C we can see the survival after surgery for inpatient and non-inpatient, almost red, which is or orange for prosthesis. It's higher survival. This is all for the aortic valve. Thank you. You can continue the mitral, or what did you decide? Is there any question?
There is no questions. You can proceed.
Sorry?
Go ahead and proceed.
For the mitral valve endocarditis, we have a surgical treatment of mitral valve endocarditis. Almost, yes, please.
One very important thing in infective endocarditis, and the surgeon experience, because the situation in the, for example, if you have infective endocarditis in the aortic valve, is depending on the degree of the infection. So the surgeon experiences play a major role. It is only the valve, it's involve an aortic root or going to the mitral valve. All that will add to the complexity of the surgery. This is one. Also, as you mentioned before, I'm just emphasizing on very important point.
Yes, please.
You need to study the valve or to study all the imaging before going, so you know your plan, what operation you are going to do before you are going. If you think there is involvement of roots or involvement, for example, of the mitral, all that, you need expert surgeon or you call for help before you are going to the surgery. Also because the bacteremia burden or sepsis, how the patient from sepsis point of view, that will affect or lead to coagulopathy and sepsis. You need to use all your tools, for example, like tranexamic acid, which have very good evidence to be used in valve surgery, but in coronary, it will affect the graft. You give 2 gram pre, 2 in the machine, 1 post pump. All these you need to put it in your mind before going to the surgery. And there is a lot of details about the picture of surgery you brought. Dr. Farid also, he sent a video that in multimedia. Myself, I saw it before. It's very good. It's very, very good video, and I advise everyone to watch it. And there is also details for the one who presenting an aortic root or reconstruction on that video. So I'm just emphasizing on all these things, and aortic valve endocarditis is not like simple AVR. Thank you.
Thank you. Okay, I will proceed with the mitral valve endocarditis.
Further.
My objective in this subject is I will start with introductions in pathology, microbiology, same again, and diagnosis. Will be clinical presentation, laboratory and echo, and other imaging, CT and MRI. Then indication for surgery and timing of surgery, which is crucial, and operative technique. We have general principle for operative technique, then native mitral and endocarditis, and for anterior leaflet repair and posterior leaflet repair for in the native mitral valve. Then for prosthesis, endocarditis, and for invasion once we need the reconstruction of mitral annulus or reconstruction of fibrous trigon. Then the result or the outcome. The mitral valve endocarditis is usually less common than the aortic more common than mitral, and most infection occur in the native mitral more than prosthesis. This is just because the native mitral we are usually repairing the mitral instead of replacing it. So repair the valve and because also having low risk for endocarditis compared to prosthetic valve. For the distribution of causes of mitral valve dysfunction, it have been changed. Before it was rheumatic fever or rheumatic valve disease, and now it's a rare entity, but still there. And also the modern medicine, which we have a degenerative valve disease, prosthetic valve, and other intravascular prosthesis, and the hemodialysis if the patient is on, and nosocomial infection, and intravenous drug abuse and immunosuppression, all that will cause mitral valve dysfunction. For pathology, for the native valve, as we mentioned before, endocardial injury, then deposition of fibrin and platelet, then attachment of bacteria, which is already there in the circulation, infective endocarditis happen. This injury either due to secondary rheumatic valvulitis or the calcification, annular and valvular calcification. This is the first spark, then after that the sequence will go on. For the after infection endocarditis, the result which we have it either vegetation will be formed, or atrioventricular separation if it's invade in, or abscess formation, or if it's going on more, it can be destructive fibrous trigon and intervalvular fibrosis. For vegetation, it's usually attached to the leaflet in the base of the atrial aspect, and for the atrioventricular separation, it's invade to the annulus and subannular area, and for abscess formation, it's invade into the AV groove fat, where it's difficult to even to handle. For the mitral annular invasion, more often it's open to toward the atrium, and that's why it's shallow, especially the ventricle is having higher pressure, so the opening will be in the atrium, so we can repair it. For destruction of fibrous trigon and intervalvular fibrosa, it's between the anterior mitral and the aorta. We have two mechanisms for that. Infected aortic valve may seed to the anterior mitral leaflet, or large vegetation from the aortic hitting directly into anterior mitral leaflet, or the jet itself, infected jet, it will go back with aortic ligament and hit the mitral leaflet. This will give extension to aortic and mitral infected endocarditis. For bioprosthesis, more common in aortic than mitral, just because we are using bioprosthesis more in aortic than mitral position. And in early endocarditis, usually occur 1% in the first year, and most greatest risk during the first 5 weeks. Then result from either intraoperative infection or other portal entry as a dental, intravascular catheter, as in hemodialysis, or even skin infection. Usually in prosthetic valve, affecting the sewing ring and complicated by necrosis, tissue necrosis, abscess, and pseudoaneurysm. This is the invasion or stage of invasion. And the mitral bioprosthesis valve may be extended anteriorly to fibrous trigon, and we have a special reconstructed technique, or posteriorly to cause AV separation. Also, there is another technique for this AV separation. For late endocarditis, it's giving only one person per year, and more than 1 year occur, which is late beyond 1 year, and the result from nosocomial usually, especially patients who having other comorbidity, give a chance of infection to get an infection more. The type of prosthesis, mechanical or bioprosthesis, does not influence the risk of infecting endocarditis. In bioprosthesis, infecting endocarditis. Microbiology, most common pathogen for native valve, it's Staph aureus, which is 7%, and more common in prosthesis valve, it's coagulase negative, which is epidermitis. And organism usually depend upon their virulence. It can be mostly with Staph 49%, and strep is less common, which is 11%. Diagnosis. The diagnosis of infective endocarditis is challenging. That's why you have to have a high index of suspicion and a very low threshold to investigate and to rule out the infective endocarditis. Clinical presentation. It's vary according to the organism. Pre-existing cardiac disease, if he has it, let's say as a rheumatic valve, and also other comorbidities and complications. Mitral infective endocarditis can be acute or subacute, which is fever, systemic symptoms, chills, poor appetite, weight loss, and new murmur, and also embolic phenomena, which can cause petechia and Ross post or oscular node and Janeway lesion. The neurological events can be happen up to 40% in mitral position. Laboratory finding, we have increased WBC, anemia, and hematuria once involving the immunological reaction in the glomerulitis. Blood culture can be separated from 2 sites before starting the antibiotic, and also 2 immediate and to be having another additional culture just before we are starting the antibiotic, unless the patient is in sepsis, so we have to have start antibiotic. Echo and imaging study. Echo is the gold standard diagnostic modality. Is TE, which is specificity 90% and sensitivity 90 to 100, which is better than transthoracic. Echo finding, we can have vegetation, periprosthetic leak, and intracardial fistula, abscess cavity. But we have to keep in mind, negative echo does not exclude the diagnosis of infective endocarditis, because some lesion can be hidden or can be missed by the echocardiogram. Role of MRI, we can do an MRI to demonstrate just the abnormality of the tissue in the annulus. This can be depend on and diagnose the infective endocarditis with it. For the role of CT, we have, if we do a CT to just manifest the metastatic infection, the liver or spleen, or even in the brain. As a pre-op assessment, we have to have CT or MRI for the brain, and to neurological evaluation, and coronary angio, as we mentioned before, and the renal dysfunction from the clinical judgment. from the contrast and pre-existing renal disease. Diagnostic criteria and their limitation. We are just depending on due criteria, and sometimes we are based on echo result and clinical and microbiological and even pathological finding. So the sensitivity and specificity for diagnosis of infective endocarditis overall only 80%. So this is the Duke criteria for the infective endocarditis, major criteria and minor. I will not go through it. After that, the indication for surgery. Sultan already pointed them out. Just I will review it again, which is a severe mitral regurg with congestive heart failure, uncontrolled sepsis, or resistance to antibiotic organism, fungal endocarditis, or fastidious organism as staph, and the presence of mitral annular abscess or intervalvular fibrous body extension or fistula, and a new conduction disturbance, which is heart block, and large vegetation more than 1 centimeter or 10 millimeter, and multiple emboli despite appropriate antibiotic, all of them surgically indicated to go on. For the time of surgery, the operation should not be delayed once the surgical indications are present, and to know the sensitivity of the organism, it's most important to be started on antibiotic before going to surgery with good antibiotic coverage. In early surgery, we have to go in locally uncontrolled infection, especially with the native valve. With the prosthesis, we have to go also early, just because we are afraid of complication, which is maybe happen. The staph aureus, rapidly progression and invasion, and the fungal, it's highly resistant organism, and both of them we can say a surgical disease. For delaying surgery, we can delay the surgery just in presence of cerebral complication, as we mentioned before. Neurological evaluation, CT and MRI proven that. If it's non-hemorrhagical, 1 to 2 weeks just to await the neurological improvement, and 3 to 4 weeks if he is having hemorrhagic stroke. And hemorrhagical stroke mortality rate, it's up to 20 to 70%, and non-hemorrhagic, if we go earlier, we may worsening the neurological symptoms. So the aim time related. And we have to weight the risk of stroke with the indication of surgery, which one we have to go. If he is an emergency, we have to go earlier. Operative technique. The general principle for infective endocarditis surgery, we have to have optimal timing of surgery, and we have to have a good exposure of the valve and radical debridement, and optimal choice of reconstruction of the heart and repair or replacement of the valve, then adequate post-operative antibiotic. For difficult debridement, mitral cases with the AV groove invasion, and as an easier debridement if it's only located in the aortic root with no invasion. For native mitral valve endocarditis, TE remain, we have to use it. For repair, 80% repair can be by expert surgeon. For replacement, 20% will be replaced, and the type according to the age and life expectancy, which valve we have to use, either bioprosthesis or mechanical. Allograft in mitral valve endocarditis remain experimental, and no one has used it. For operation, we will just median sternotomy, cannulation, then myocardial protection, exposure, we have to extend sometimes the exposure, left atriotomy through the interatrial groove, or transeptal through the right atrium. Then we have to evaluate the disease, resect, and we have to send two specimen culture, one for culture and the other for pathology. This is the anterior leaflet repair. Repair with anterior leaflet perforation using patch of autologous pericardium, and we have for approach either repair or depend upon the lesion. Repair with the autologous pericardium, especially in kissing lesion, and or require the freestanding aortic root allograft, or triangular resection for the free edge. This is all of them we have been discussed before in the mitral repair, and also the chordal transposition in the anterior leaflet. We will take the chordae from the posterior and the transposition to the anterior leaflet. The other one is artificial chordae. Once ruptured, we can put an artificial chordae. This is the perforation in the anterior leaflet. Then after patch pericardium repair, here the resection of the posterior leaflet, quadruple resection, then enforced with the annuloplasty ring. Although this foreign body carry high risk for reinfection, but we have to we are putting just to prolong the repair durability. For the posterior leaflet repair, as we mentioned, triangular or quadrangular resection, and the annular resection with the autologous pericardium. If replacement is required, mechanical or bioprosthesis, then we have to insert and affix the prosthesis to the patch, and the other one, prosthetic annuloplasty ring in native valve is necessary. For prosthetic valve, operation for prosthetic valve are reoperation usually should be as a reoperation, and we have to have a CT chest just to know the for the proximity of the sternum and the heart, and there are two way, either medial sternotomy, which is more common and all surgeons use it, and the right anterior lateral thoracotomy in the fourth intercostal space if we have multiple sternotomy or we have difficult access. But in this approach, we have a higher risk for stroke because difficult cross-clamping. For reconstruction of mitral annulus, first of all, exposure most important, and prosthesis is removed, then debridement, then after that reconstruction, either by David technique or Carpentier technique. Carpentier usually just he's taking a suture and approximate the AV separation together. For David technique, he's applying the patch beyond the annulus part in the ventricular site and also beyond the atrial part in the beyond the annulus, also in the atrial part, and he is sewing all the way, and then he takes the bridges or the valve suture within the patch in the defected area. This is once the annulus is affected. For reconstruction of fibrous trigon and intervalvular fibrosa, once especially in the prosthetic valve, extension to the intervalvular fibrosa or fibrous trigon required reconstruction of intervalvular fibrosa as well as replacement of both aortic and mitral once it's extended there. By using autologous pericardium or bovine, first exposure, then debridement at the same end. Then after that, mitral valve prosthesis to be sewn in the annulus part. Then pericardial patch to be support the anterior part and replace the intervalvular fibrosa, then aortic valve, fixing to the annulus part. We can see here, this is the reconstruction fibrous trigon. Here the exposure through the aorta and after removal of both aortic and mitral prosthesis. Then we are dividing the intervalvular fibrosa, and after that we are affixing the mitral prosthesis there, where we are leaving the anterior part not sewing. Then the pericardium patch is used to just cover the left atrial floor and the fibrous trigon and to the anterior part. Then after that we are applying the allograft and aorta to the to this patch in the posterior position. For the result of native mitral valve endocarditis, the outcome is worse than aortic valve usually. Just due to the invasion of mitral disease, it's usually surgically difficult in exposure and in debridement, and also in repair. For the mitral valve repair compared to the placement is superior, as we are seeing in the chart here. Repair is superior to the replacement in event-free survival and low hospital mortality, and also improve long-term survival. For prosthesis, this we come across before. The outcome of medical therapy alone very poor, and early endocarditis, which is higher operative mortality, and in outcome are worse of invasion, mitral infection than invasion in aortic. As the invasion in mitral, it's difficult to expose and to repair. And thank you. Any question?
Thank you.
شكرا خليفة.